Good morning, everybody. We will go ahead and get started this morning. Welcome to the June IP call. Today we're going to talk a little bit about SSI, surveillance and reporting for NHSN, and we will hear from Nancy Wild. So I am right away just going to go ahead and hand this over to Nancy so we can go ahead and get started, and then we will come back through and do your HIIN, IDPH, and Telegen updates. So hold on one second here. Nancy, I'm going to hand this over to you. Are you on the call, Nancy?
I am. Thank you.
All right.
Can you see my...
Hold on one second. It's just passing over to you. So.
Okay. Brand new computer today, so it's a little throwing me off. Let's see if that works. Can you see my screen now?
Hold on one second here. I am not seeing your screen. Were you able to see my screen before?
Yep, and now it's disappeared.
Okay.
I can see that the sign-on, but I can see that people are there, but I can't see your PowerPoint. All I see is the IP call June 13th.
And it is not showing up on my screen.
I tried to send you my presentation just in case this happened. Did you get that? Can you pull it up?
Yes, I can sure do that. Hold on one second.
I wasn't trusting in my computer.
All right. There we go.
Ah, that's
now
working. I can see it. There you go.
All righty.
Great. Okay, and we'll go right into the second slide here. We're just going to review some surgical site information real quick here, and I understand that this is only an hour call, so you'll be surprised at how quick this is going to go. I'm not going to go into tons of detail, but one of the priorities here is I just want you to understand, and I know you all do this, but why surgical site surveillance is important. And obviously, when you look at the number of infections, SSIs and pneumonias are two of the most commonly occurring HAIs. And we're all looking at different aspects in healthcare, how you cut down on readmissions, how you decrease hospitalization stays. And when you see here that it's a study by Murkow and Chung that 20% of SSIs account for 20% of unplanned readmissions after surgery. They also account up for approximately 11 days on average for each SSI per patient. So they are definitely an issue that your entire organization should be interested in. So if you can click to the next one. When you guys call me with questions on SSIs or any type of NHSN questions, these are the types of things that I usually go to for answers. So I wanted you to have a chance to see how many, these are the frequently asked questions, and these are all brand new. They were just loaded up in April of 2016. These are based on the new definitions as of January, so these are going to be some questions that you can go to if you have something pop up in your facility. you may get your answer right then and there. You can always call me, but this is where a lot of times I go to for my information. If you haven't already, that very top, the chapter Identifying Healthcare-Associated Infections for NHSN Surveillance, it's important that you have access to that. And I personally print them off, but I know a lot of you just bookmark those and just pull them up on your computer whenever you need to, whatever works best for you. But wanted you to understand that there's a lot of information out there that you can access. And the next couple of slides are some additional information that you might want to look at. So if you wouldn't mind, go ahead and forwarding that on. Here again, the data collection forms, and it didn't, I had a couple of arrows, but they didn't translate on with the new edition. So do want you to notice that the table of instructions there, under each one, for every form there is a table of instructions that you can go to. If you don't know what you're supposed to put on a line, you can just open up the table of instructions, and it'll tell you specifically how to respond to each question. So I actually use those a lot when I get a question that I can't answer. So I just wanted you to be aware that you can go out and look at that. And the next slide.
I'll tell you that. And it's not big stuff, it's small stuff.
Oh boy. So you can go to the next slide.
That's correct.
Okay.
If we, well,
the other thing.
Yeah, I guess that's, my brother may be buying it. I don't know if he doesn't want to fill in at an auction.
People
I'm not exactly
that
sure
aren't
how
muted, if you want to go ahead and mute your line.
Yes. That's the discussion is, I personally am interested in selling the acreage part off. My brother is less enthusiastic.
You guys can go ahead and mute your lines if you're not talking. That would be helpful. Okay. This one also, with the new changes of the ICD-10, this gives you a list of the codes that you can look at. I'm getting some feedback there. I don't know if somebody can mute their line that maybe is not muted. Okay. And I'm sorry, Jennifer, if you can go ahead and go on to the next one. I get a lot of questions, especially from new IPs, on what you need to be looking at and how you determine SSIs. So just for those of you that may not have been doing this a long time, the first thing that you want to do is to determine which surgical patients you're going to follow. And I know that a lot of the bigger hospitals have defined that pretty well, but for some of the smaller facilities, you really need to identify what is actually a surgical procedure, what is it that's being done at your facility, what's your priorities, and which patients you're going to monitor. And in a lot of critical access, they want you to follow all of the patients, but you may not be able to do that. So you need to look at what's being done in your facility. And your risk assessment that you do every year can help you work through and determine which surgical procedures you're going to be looking at. So to determine whether or not somebody has an infection, one of the things that I found very helpful was admission logs. When I see somebody coming in that usually had an admitting diagnosis that I could look at, and a lot of times if it was related to an infection, it would be post-op surgical wound infection you could look at. ER admissions is another one that you can review. You also want to get out and look at charts whenever you can, talk to the staff, review nurses' notes and physician notes. But I think that priority there is to just be aware of what's going on in your hospital and so that the staff knows that they can talk to you about things. So going on to the next one. So when they're inpatient, it's a lot easier to look at, but that post-discharge SSI surveillance can be a little bit more tricky. Some of the things that work really well for a lot of hospitals is sending out a list to the surgeons and asking them to tell you whether or not somebody has had an infection when they've come back in for your post-op visit. That works really well for a lot of cases, and most of you have pretty good rapport with your physician offices and are able to get information out pretty well. or get information back in. Another thing that you can do is to look at, and some of you have access to post-op clinic records, and obviously, again, looking at readmission and ED diagnosis. But keep in mind that regardless of whether you're getting that information, you do need to apply the criteria to determine whether an SSI is detected. And sometimes you'll get a response back from a physician that there was cellulitis, it's an infection. You may need to get additional information to know if it's going to meet your definition. So don't be afraid to communicate with the offices if they're seeing somebody in their clinic and they indicate that there was a problem with the wound. Oh, sorry, I guess I can't go forward with the slide, so if you'd go ahead and go to the next one. I wanted to just review a couple of terminologies or terms with you real quick. The NHSN operative procedure is used pretty frequently as to when you're deciding what you need to do. So an NHSN operative procedure is, it's got to be on the list of the ICT, the CPT or the ICD-9 codes, oops, ICD-10. I'm kind of outdated there. It has to take place during an operation where there's an incision made, even if it's a laparoscopic approach, through the skin or mucous membranes. And it has to take place in an operating room or an area that meets the definition of an operating room according to the American Institute of Architects. So that could be a C-section, could be an interventional radiology room or cardiac cath room, in addition to your regular operating room suites. So if you can go forward, Jennifer. Presence at the time of admission, or present at the time of surgery, yeah. Sorry about that. So a PATOS as surgery present at the time of surgery. So that what that's saying is that there was infection at the time of the start or during the index surgical procedure. It is not found on the denominator form, but that is a thing that you would mark if you're reporting a surgical site event. And there has to be definite evidence of infection or abscess noted in the operative notes. So you will need to look to see if that's the case. The advantage is that when you're reporting your denominators, that's not a piece of information that you're going to have to collect. When that becomes an issue is when you're looking at an infection. So that gives you an opportunity to go into that surgical chart. So if you can go to the next slide. I actually have 3 slides on the PATOS. So one of the tricks here is that it's only going to be responded that it was present at the time of surgery if it's the same level of, the infection is the same level as a surgical site infection. So if you had somebody that had evidence of an intra-abdominal abscess and 2 weeks after surgery they wind up walking into an office and they have a superficial incisional infection, that does not count. You would not mark that present at the time of surgery box. It has to be at the same level of infection that was seen at the time of the surgical procedure. So going on. And that's how you report that. So when you report an event, there's just simply that little box there that you would mark present at the time of surgery. And you don't have to apply any definition to that for that box itself, but if they've documented infection and it's the same level of infection, you would mark that. So next slide, please. Date of event is simply the date of where the first element is used to meet that SSI infection criteria for the first time during the infection surveillance period. So the first temperature, the first culture, the first time that wound is opened. So anything that's going to help meet that definition, that's the date of event. The next slide. I get this question an awful lot with inpatient and outpatient. For CMS rules, they are asking you to report inpatient procedures. Some facilities in your risk assessment, you are doing both inpatient and outpatient of certain surgery types. That's totally your decision, but how you define that is an inpatient operative procedure is one where the date of admission and date of discharge are on different calendar days. It doesn't make any difference if they're there under an extended OBS or if they're actually admitted to the floor. If they come into your facility on one day, leave on a different day, that's an inpatient procedure. Outpatient is when they are in and out on the same day. So next. Denominator data is, you look at procedures done in 1 month. You complete a denominator or procedure record for every operation of the types of codes that you're following. And if it's in your reporting plan, then you for every single one. So if you do 20 colon procedures in a month and you're reporting on colon procedures, you would do 20 denominator forms. They do ask that you do this in a timely manner, and the denominator information is actually much easier to get in a timely manner. What sometimes, because of the surveillance periods, it's harder to get your events entered in, but you do have to wait until the 30-day or the 90-day period is surveillance period is over. But for the denominator data, you should be able to get that in a pretty timely manner. So we'll go through to the next. Some of the things on the procedures that can be difficult to get if you're trying to look at, as you're doing your chart review, I just wanted to touch base on a couple of things. There are a lot of you that are able to pull information from your electronic medical record and it drops into a spreadsheet. Some of you don't have that ability to do that. Wound class is one of those things that can be a challenge. It's on your denominator procedure. It is required for every procedure that you're reporting. You identify whether it's a clean, contaminated, or dirty. We used to call those 1, 2, 3, and 4. The wound class, it should be done at the time of the procedure, and it is usually performed and assigned by somebody who's actually in the operating room, so a scrub nurse or circulating nurse. It's not usually something that has to be done by the IP, although if you see something that doesn't make sense, I would go back to them, and we saw a lot of hysterectomies that would be coded as a clean, and you can't enter the vagina is not a sterile cavity, so those should always be a clean contaminated at best. Going to the next. This is another, and I just kind of mentioned to you that the outpatient procedure, if they are in your facility at least overnight, they're going to be an inpatient. If not, then it would be an outpatient. Probably the trickiest piece of information to get when you're pulling those records is the duration of the procedure. It needs to be done in hours and minutes. It's a lot of times when you're looking at the chart, you'll get a start time and a stop time, and it's not usually recorded in hours and minutes, so that's something that a lot of times it's difficult to calculate or to pull from a record. So going on to the next slide. There you go. All right. Hoping that it all makes sense anyway. I thought that was kind of cute, and it gives me a little bit of faith that maybe we'll all make it through all the reporting that's coming on through from NHSN. So we'll go ahead and go on to the next. Thank you. So there's 3 different levels of surgical site infections. The first one is the superficial incisional SSI, and that occurs within 30 days after any NHSN operative procedure. It's only going to involve the skin and subacute tissue. They have to have either purulent drainage or organisms obtained from an aseptically obtained specimen. And what NHSN tells me basically is that if it's something that they're in a physician's office or in a clinic and they're doing that, they're using a swab, you would consider that an aseptically obtained specimen. So you don't need to try to identify how that's done. So going through to the next. If the physician is deliberately opening it or and that will count as long as it's not culture negative. So if they did a culture and doesn't grow anything. The fact that they open that doesn't meet that criterion. But if they open it and don't culture it, that can meet that. In addition to that, they also have to have signs and symptoms of pain, tenderness, localized swelling, erythema, or heat. Or for superficial incisional, if it's a diagnosis by the surgeon or attending physician or other designee, it can meet the definition of a superficial incisional infection. So moving on. Just a word of caution here. We get a lot of reports of, somebody has cellulitis after the incision. That in itself is not considered an SSI. If it's draining and has a positive culture, it's not considered cellulitis, even though the physician may say that. But just simply a reddened incision with a diagnosis of cellulitis does not meet the definition of a surgical site infection. Also, a lot of times there will be just a little small stitch abscess with minor inflammation, and that's not considered a surgical site, or a stab wound is not considered a surgical site. Now, a laparoscopic trocar site is not a stab wound, it's considered an operative procedure, so you would count that. So, next slide, please. This is the chart that's in your definitions that you can print off, and it does talk about whether or not the procedure should be monitored for 30 days or 90 days. I know you've all seen this. The majority of the procedures that you're looking at, the colons and HIIS, are going to be in that 30-day. Your total joints for knees and hips, hernias is another one that falls under that 90-day procedure. Now, if it's a superficial incisional, you are only going to follow superficial incisional infections for 30 days. So even if it's on that 90-day chart, if it's superficial, it's not going to count if it's after that first 30 days. Going on to the next. The monthly reporting plans are very important as you're setting this up, and I should have had this slide in earlier, but determining what you're going to follow is important, and then making sure that you have that established. You're going to report superficial, deep, and organ space infections. And I can't tell you usually how much your reporting plan makes a difference in what you're reporting and how it shows out. So if there's an issue with your data, I usually go to the reporting plan first and find out if it's something in the way your reporting plan is set up. So if you want to go to the next slide, we'll just keep going. The deep incisional are for those infections that go into the deeper tissue, into the fascial and muscle layers. It can be either the 30 days or the 90 days after the procedure, depending on that table that we just looked at. And they have to have purulent drainage from the deep incision, or something that spontaneously dehisces or is deliberately opened by the surgeon or attendee. There again, if it's cultured, if nothing grows, it's not going to meet that definition. Now, they also have to have a patient that has to have at least one of the following signs. So those fever, the localized pain or tenderness, an abscess on imaging tests or exam. I'm going to go to the next. What would meet that? And then you get into the organ space. And organ space is a little bit more complicated, only because for an organ space, it has to meet the definition of a surgical site infection, but it also needs to meet the definition of the organ space infections that are listed. And I don't know that I put that table in here. I think it just, so if you have an abdominal procedure, you could need to meet the definition of infection, but you also need to meet the definition of an intra-abdominal infection. And for a hip, you would also have to have those joint infection, those types of things. So that's where you're going to get into a little bit more complicated. So it has to have purulent drainage, organisms that are from fluid or tissue in the organ space, abscess, and other evidence of infections, that type of thing, and then, of course, going into those other types of infections. Let's go ahead and go next. So there again, there is a list of the definitions that you have to meet, so you're going to have to apply 2 different definitions for an organ space infections, and if you have any challenges finding that, I can help direct you to that. But this slide there will give you that information of where you can find that. Okay, and next. Oh, here it is. Those are I didn't think I had to put in there. So these are the other types of infections that would need to apply. So you can see there that you've got the opportunity to have a lung infection, mediastinitis, oral cavity, other infections of the male or female reproductive tract, those types of things that can be an issue and can be an organ space infection. And that is all available on the NHSN website. So let's go ahead. I like this, I put this in, it's just a little teaser here, but it does give you an opportunity to look to see what types of, so if I have a leg amputation, what type of organ space infection I may need to look at. So in this case, a limb amputation, you would need to look for an osteomyelitis, for joint or bursa infections. It can also be a deep incisional or superficial. So it gives you an idea of what type of infection can apply for each surgical procedure, and that again is in the surgical site infection definitions. And somehow I got this out of sight. But present on admission is not going to apply for a surgical site. So for the other types of infections that you look at, except for ventilator-associated events, you're going to apply a present on admission criteria. For a surgical procedure, that can't be utilized because obviously the surgery is the intervention that you're looking at. It also, we will occasionally hear an argument that if it was a dirty case, why would I report it? You would still, regardless of that wound class, you would still report that and count that as an SSI. Present at the time of surgery is also another thing. You still report the procedure, you still report the infection, you just mark that box. So we'll go ahead, and that brings me to the end. And I know that you guys do a lot of these things. I'm hoping that you guys are comfortable and having some discussion. One of the things that I do get a lot of questions on is that post-discharge surveillance, and I didn't know if any of you were comfortable or had any experiences that you wanted to share on how you got that started or any problems that you've been having with that.
I have a couple of folks muted on here. I'm going to go ahead and unmute all the lines so everybody can speak freely. But please, if you are not speaking, please be sure to mute your line so we don't get any background noise. And please don't place us on hold because then we'll hear the hold music. So I'm going to go ahead and unmute everybody now so you can go ahead and chime in if you have a question or a comment, or you can also type it in the chat box as well.
And I see there's a question here about sending out slides. I'll be happy to share my slides.
Nancy, this is Cheryl from Atemo. I have a question, and it has to do with the SSI part. If we do all of our surgeries in the same OR, whether you're inpatient or outpatient,
okay.
So I report abdominal hysterectomies, and even though they are an outpatient, is that correct? That's what I've been doing because they're done in the same OR.
It's not incorrect. The only thing is that it's not a requirement for CMS to report all of them if they're not in your facility overnight, and you would want to distinguish whether or not they stay overnight or not. So obviously if you're doing that and that works for you, that's great. That's why I say it's just a matter of you defining what you're going to report, but you're not required to. Does that make sense?
I think so, because in my plan on NHSN, I have that I just do inpatient abdominal hysterectomies, you know, for the reporting piece. But I always report like every abdominal hysterectomy, so then I have to mark the box outpatient, and then I think that usually throws it out, so then I go ahead and mark inpatient, even though technically it was probably an outpatient. So I'll watch that better, or I change my plan. Is that correct?
Exactly. And either way, I mean, it's whatever is going to work for you is fine. There are other facilities that are doing that and reporting outpatient just for the reasons that you define. It's something that they've identified as something they want to monitor in their facility. It's all done in the same OR or by the same staff, and so they've decided to go ahead and monitor both. So you're not the only facility that's doing that, but if you're going to do that and report them all, just modify your reporting plan.
Right. Okay. Thanks. And then I would say one thing about the surgeries that go, or your list that goes out to surgeons. So we send a spreadsheet, and actually the surgeons like it because for them it's an easy way, if you will, for them to say, oh, I had 100 surgeries this month. I had X number of surgeries this month. So it helps them look at their total number of cases and what types of cases they had. So I think, I don't know, that's just what they like, and so it's an easy thing that they're, you know, happy to send the report back as well.
And I appreciate that. I think that what I'm hearing is that once you get them started on it, it goes pretty well. Has anybody had any bad experiences with that? Or any challenges maybe? Does anybody have any other questions? And I see a note here that occasionally it can be hard to get surgeons who are not full-time at the facility to get their lists back in time. And I totally agree with that. That can be a challenge. One of the things that I have found that may be successful is to try to engage a clinic manager or nurse or somebody that can kind of help with that. But that time frame can be difficult. And bottom line is, if they're seen within that 90-day period, if it's a little bit outside of that before you actually get it reported, still report it. It's important that you still monitor those and still report them if it's something that you're doing for your facility. But a lot of times if you can just get somebody in the office to designate or to find out and just fill it in with the best information they have. But yeah, if they're not there a lot, they're not as invested in your program.
Nancy, this is Barb at Knoxville.
Hi, Barb.
A question about when you were talking about cellulitis, and if it's outside the 30-day window.
Yes.
If that includes hardware that's, you know, exposed or through skin points, does it not count as cellulitis if it's a cellulitis after 30 days?
So in like a procedure like an ORIF where they have external pins type of thing?
Where they get external pins, yes.
Yeah. No, if it's just cellulitis, it's not going to meet that. Now, what I would look at, though, is there drainage involved in that? Because if there is, then you need to look at that because the drainage may apply. One of the things to consider is whether or not the procedure that's done, and I think of, actually meets the definition of an NHSN procedure. Because what I'm trying to determine here is, would this be something that would be maybe a skin and soft tissue and not a surgical site infection? So there may be some other things that you'd want to look at with that.
All right.
I know a lot of times, like with bunionectomies, there'll be an external pin. and that's not going to be on the surgical site as the NHSN surgical procedure list. So then I might look at that as being a skin and soft tissue and figure out if that meant the definition.
Okay.
But ORAF, I think those are on the surgical list. So, but no, cellulitis in itself, regardless of whether or not it's within 30 days, isn't going to meet it.
Okay. Thanks.
And I think sometimes that confuses the surgeons because they think that if it's if they put cellulitis, that it's probably an infection, but it wouldn't meet your definition. Anybody else? Well, then I think I'll turn this back over to Jennifer.
Thank you very much, Nancy.
Thank you for your help with the slides.
Not a problem. All righty. So I just wanted to share this with everybody, just so you kind of have a snapshot of our current performance. I just have the abdominal hyst and colon SSI performance here. So this is HIIN-wide. This is our HIIN rate. The data comes from NHSN. Percent of improvement from the baseline, and this is just for the performance period of November 2015 through January 2016. We've seen a 13.84% improvement in abdominal hysterectomies. And for colons, we have seen a 13.73% improvement, again, from baseline to the current performance period, which is November through January 2016. So there's just kind of a snapshot of where we are with HIIN data for some of the SSI. So going on to a HIIN 2.0 update, again, NHSN data, that's where we get all your HAI data, called ECLAB-C, C. diff, SSI, and VAE. I still have a couple hospitals out there that have not accepted the new rights template, which gives me the ability to pull your facility-wide in C. diff data. So if you have not yet accepted the new rights template, please do so. The HIIN Hub, we are moving to a new platform for the HIIN Hub. That should be coming in the next couple weeks. So as that happens, I'll send out email updates to all HIIN Hub users, letting them know what the plan is for that. When they health doers, when they do the full move over all the users and everything, the site will be shut down for a few days. So just keep that in mind. But again, I'll let everybody know when that is going to happen. When the new site comes out, it's going to look different. There's going to be some enhanced usability. It's going to be more user-friendly. Some additional resources that are available through the HIIN Hub. So when that does happen, we'll let everybody know, so you'll be able to go on and get going with the new platform. What I understand from our vendor is when we move to the new platform, all current users will get an email to go on, and you'll have to sign in and put in your new password, put in a new password. So just to give you a heads up that will be coming. Goal reports were sent out earlier, the middle of May, to all hospitals. If you have questions regarding the goal reports, please contact Jennifer Kriegmer or myself. We've had several calls and visits with hospitals walking through the goal reports and what they mean. More than happy to do that with with the quality folks, the IPs, your CEOs. So just let us know if you have questions. The HIIN Learning Community is tomorrow. So if you have registered, great. We hope to see you there tomorrow. If you have not registered, that's fine. You do have the ability to register on site. The HIIN Learning Community is free of cost. There's no registration fee. And for critical access hospitals that participate in FLEX, we are offering a $175 travel stipend to each hospital. So talk to your quality folks, and if you aren't coming, I encourage you to come. The Care Coordination Conference is the following day, so that is going to be on Wednesday of this week. Lots of great stuff around community collaboration, public health, health disparities, those types of things. So that's also going to be a great conference. Also, I'm going to be sending out some webinar information for the Sepsis Initiative Network for the webinar series. They've been doing them once every month, I think, and great resources there. So I'll be sending that out to all the IPs so you have the ability to join in on that. So for HIIN, we have some new news for the Hospital Improvement and Innovation Network, which is the next iteration of the HIIN. It will be called the HIIN. New baselines will be established starting in 2014 and going forward. Bold new aims. So they're going to change the aims. Originally for HIIN and HIIN 2.0, it was a 40% reduction in healthcare acquired conditions and a 20% reduction in readmissions. We are now looking at a 12% reduction in readmissions and a 20% reduction in all-cause harm. We're looking at those hospital-acquired conditions. The baseline is going to be that 121 healthcare-acquired conditions over 1,000 patient discharges, which is what we had achieved as of 2014. The other thing that CMS is strongly encouraging is strong partnerships with our QIOs. In Iowa, we work really closely with Telegen. We have a really strong partnership with them, and so that will, upon award with HIIN, whatever happens with that IHC will continue to work with the QIO as well as IDPH looking at healthcare-acquired conditions, healthcare-acquired infections. So the HIIN areas of harm have changed just a tiny bit. So originally with HIIN and HIIN 2.0, we had 10 focus areas, and one of those included OB harm. So for HIIN, they have removed OB and added 2 additional core focus areas, which are C. diff and sepsis. So now we're up to 11 core focus areas for this next iteration. Additional focus areas that they're encouraging HIINs to consider are MDROs, antimicrobial stewardship, diagnostic errors, malnutrition in the inpatient setting, airway safety, iatrogenic delirium, exposure to radiation, and culture of safety. So some of those we already do. We do the undue exposure to radiation and culture of safety. We're looking at options for some of these other focus areas. And as we get closer to award, which is tentatively set for the end of September, September 30th is when they plan to announce awards. We will send out draft measure sets so hospitals can start looking at that, and then we'll move forward if IHC is selected as one of those awardees. So any questions about any of the HIIN stuff from anybody? All right. Nancy, did you want to give a IDPH update?
Yeah, this will be really brief. We do, and I'm very glad to say that we have a new employee today. She's going to be a field epi, and I'm not sure, we haven't determined which county she's going to have, so we'll get that information out to you. And a new position in-house as an in-house epi has just been approved, so we'll get that going and get that posted here soon. So that's about all I have. Thanks.
Thank you. And then, Kate, are you on the phone for Telegen?
Yes, I am.
All right. Would you like to give the Telegen update?
Sure. Not a lot has changed for us in since the last call. We are still continuing to focus on C. difficile infection prevention and reporting in the long-term care arena. Oh, that's my favorite slide. I love that slide. It really demonstrates that CDI is no longer just a hospital issue, but it's becoming a community issue. So even beyond going from hospital to nursing home, we want to look at community level antimicrobial stewardship, you know, so taking it really just beyond the healthcare settings and getting it out in the community. And we have that in the slow cooker cooking, and Cheryl will probably have more the next time you guys meet. That's all I have.
Thanks, Kate. Do we have any questions for Kate or for Nancy? Okay, well, I'm gonna go ahead and open this up to open discussion from anybody, anything related to HIIN or any other questions that you may have. All right. Our next call is August 8th. We do not have a call in July. Again, the HIIN Learning Community is June 14th, and the Care Coordination Conference, June 15th. Coming up into June and July are the CA Regional QI Coordinator meetings, which are led by Mary Beth Sorensen. And there are the dates listed there: June 28th in Storm Lake, June 29th in Atlantic, July 6th in West Des Moines, 7th in Ottumwa, and July 21st in Waterloo. Team Steps workshop, on-site workshop, will be held at the IHA Education Center here in Des Moines on July 13th. And this next SIM Learning Community is on July 12th in Altoona. More information about any of those meetings are on our website, so if you have questions about them or curious, you can take a look at them there, or you can email any of us at IHC, and we'd be happy to get you more information. So thank you, everybody, for being on the call today. The next call on August 8th, we'll talk about best practices for prevention for SSI. In the meantime, if you have any questions for Nancy, myself, or Cheryl at Telegen, please feel free to send us an email or give us a call, and we'd be happy to help you out. Thank you, everybody.